Hello and welcome to this PowerPoint presentation of the preliminary steps required prior to participating in our DayCOR Anaesthesia Outcomes Recording Registry. I'm Ken Sleeman, Chair of the DayCOR Anaesthesia Special Interest Group, which has created this Outcomes Registry. We have done so due to the paucity of information available to us after the discharge of our day surgery patients. Hospital-directed phone calls to patients the next day have a capture rate of less than 50%. It uses up a large amount of nursing time, which has been redirected to PACU nursing recently due to the frustratingly low response rate. Our SMS survey has created an excellent method of contacting patients with greater than 85% capture possible. There are many reasons for having a registry besides the obvious better management of problems such as pain control, post-discharge nausea and vomiting and comorbidities, and especially a new one such as obstructive sleep apnea diagnosed during the preoperative consultation on the day. The registry provides information for hospital and practitioner quality assurance studies, improving risk management, but it also initiates discussion both informal and importantly in the tea room and at formal structured meetings. It enables the initiation of change in patient selection. Patients having certain types of surgery, some breast, thyroid, laparoscopic banding or ERCP, may be suitable to have their status changed to daycare. New procedures may emerge as day cases, and we are able to evaluate the success of initiation of any change. And finally, it provides evidence of high standards for bodies responsible for safety and quality standards, for health departments, private health funds, and of course the community. This is step 3 in the process of organising your entry into the registry, and we presume that you've already read the DayCOR Outcomes manual, or at least have it in your possession. Everyone should understand that this is not a popularity contest, but a registry creating reports for every level to ensure that the highest standard of care is being given. Now there are 7 preliminary steps. Consultation with your fellow anaesthetists, consultation with administration, with your fellow colleagues, surgeons and proceduralists, of course consultation with nursing administration, and setting up a hospital steering committee, ensuring that educative processes are in place, and understanding the reports which arise out of the registry. Now, consultation with your fellow anaesthetists. There will have been much discussion over the years and also currently concerning the paucity of information received after a daycare patient goes home. In private practice, some may already have an arrangement with surgeons whose rooms contact patients the next day. They could opt out at this stage, although we would want them to join in when the final version is launched. Consultation with administration. As DayCOR Outcomes is a new concept, hospital administration may need to satisfy local board policies, but you can inform them that the entire program is based on the Clinical Care Registry, or CQR, framework and format of the Australian Commission on Safety and Quality in Healthcare. This body has been charged with the introduction of CQRs by the Australian Health Ministers Advisory Council to ensure good quality assurance at all levels, medical, nursing and administration, and providing reports to all levels from clinician up to get the highest and most efficient standards of hospital and medical practice. Consultation with your colleagues, surgeons and proceduralists. Probably best initially to seek a medical advisory committee support or senior medical staff committee approval, and when approved all staff can be advised. But surgeons have proved to be most encouraging and supportive, not only for our purposes. They realise that we are saving them some issues by often identifying their problems early, especially bleeding and hematoma pain. And it's certainly advisable that you have a lot of discussion with your surgeons over the drapes. Consultation with the nursing administration, which would also occur at the same time as these other consultations. Nursing administration should be pleased that the PACU staff are not expected to contact the previous day's cases to check on their well-being. It was always a frustrating exercise when done, with less than 50% contact rate. But now the discharged nursing staff require special attention, as they will introduce the survey by completing the login page with the patient on discharge. As this requires only checking mobile number and or email address, will not take long with the patient, and the rest of the information required should be readily obtainable from the medical record. I can't stress enough that it's very important that this information is correct, otherwise the patient may not be contactable. The Hospital Steering Committee. At the same time as other discussions are underway, you can look for recruits for the hospital committee to run the program. Some are obvious by position: directors of day surgery clinics, day surgery ANUMs, and other interested anaesthetists are always good recruits. You should, of course, follow hospital policy, but be guided by the necessary personnel required to oversee these activities. And don't forget a surgical representative and interested young anaesthetists, who may be the people who produce papers later on. Education. All staff can educate themselves by running through the program steps in the manual. It's a simple registry program, but all staff, medical, nursing and administrative, should be aware of its processes and the results which will follow. The discharge nurse group will easily understand their role, but should practice it so that they are aware of the possibility of input errors which may result in the inability to contact patients. And finally, reports which arise out of the registry. Reports are a very important function of the registry. Alert reports from SMS surveys will come to the responsible anaesthetist and to the hospital steering group as a group email to designated members. This is most important as new situations such as pain management, post-discharge nausea and vomiting were formerly undertaken by outside agencies such as general practitioners or emergency departments, and these are the things which will appear in these responses and have to be acted upon. They'll be managed in the first instance, of course, by the responsible anaesthetist, but you should be aware that the responsible anaesthetist may be unavailable and the steering committee will have to take over to sort out the alert report sent in by the patient. In summary, this SMS survey style registry is easy to undertake with understanding anaesthetists at the helm to share the load of staff queries and to ensure correct responses to alert reports. The SMS reports are automatically de-identified before being stored on the server, but identifiable responsibles are available only to the patient's anaesthetist and to the steering committee initially to enable patient management.